meeting in public. Welcome governing body members, welcome to members of the public. Today's Remembrance Day, so at 11 o'clock we'll be switching off cameras and microphones for a 2-minute silence. So we'll move into the agenda. So housekeeping, well, we're all in different places, so you should all be aware of how to keep safe. We're using Teams. If people wish to speak, please use the raise hand function if you can. If you can't, then wave a hand and we'll look out for you. So we move on then to apologies, and we've heard Dr. Kadasha has to leave us at 12 for the CQC visit for his practice. Any other apologies, Kay?
We have Jane Sibakumar and Chris Millington will be joining the meeting later.
So Jane, and we've got people to do Jane's items, and Chris Millington. Okay, and Kay, are we quorate?
We are quorate, yes.
Thank you. So can we then move on to item 4, Kirsty, the patient story?
Hi, thank you. So today's patient story links to a paper that we've got later on the agenda, and that's the Children's Assessment Unit at Barnsley Hospital. And I want to introduce you to Rhiannon today. And Rhiannon's going to talk to us about her trip into Barnsley A&E and what happened when she actually visited the Children's Assessment Unit. So Rhiannon, would you like to give us your story?
Hi, I'm Rhiannon, and mum to Joseph and Dan. Joseph's 13 weeks now and is doing much better. It was about a month ago I had to take him through to A&E up at Barnsley. He'd never had any problems before that. He arrived on his due date and all his checkups after that had been fine. It was just the normal things that you worry about with a baby. I think you just get by on adrenaline for the first months. It's definitely not sleep. It was a Thursday afternoon when I noticed Joseph was a bit off it. My mum comes and helps with Dan. He's nearly 4, but he's got a couple of serious health conditions which requires him to have a bit more care and support. My mum's brilliant with him. She comes most days and collects him from nursery, especially now I've got Joseph. Anyway, I was upstairs feeding Joseph when my mum came up to say she was back off home. She said she'd noticed he was a bit more sniffly. He wasn't feeding that well that day either, which wasn't like him. My mum said to keep an eye on him. I was really worried, to be honest. I thought it could have been a cold, COVID. I mean, you just don't know, do you? And we've had so many health problems with Dan. I kept thinking that it was something, a sign, something we hadn't spotted. Anyway, I didn't take my eyes off him, and he seemed to quieten down that evening, but the next morning it seemed like he was struggling with his nose and his breathing. I left it a bit, but I didn't want to take any chances, so I took Dan to my mum's and I took Joseph up to A&E. We got there at 8 in the morning. There were already quite a few people there. Joseph was seen quite quickly, so that really worried me because it made me think like it was something very serious. They don't mess around with babies, do they? They said that Joseph probably had a viral illness called RSV. I'd never heard of it before, but they said that he didn't need medicines or treatment. I was terrified he'd get worse, but the nurses were brilliant. They took us through to another section to keep him under observation. It's the new bit where they look after all the kids. It definitely seemed more suitable for us in there. I wouldn't say it was relaxing, but it was bright and nice for the kids, and it meant you could keep all the kids together rather than mixing with the adults. They kept checking on him and me, and he seemed to settle a bit, but I knew he wasn't himself. Luckily, he didn't need admitting, which was a relief in some ways, but worrying in others. I was worried how I would manage with Dan if they kept him in, and also worried about taking him home in case it got worse. I feel so helpless when they're babies and they can't tell you what's wrong with them. But the nurse explained all about what RSV was and the things I should look out for, and taught me through his feeds. They kept him in for the rest of the day, and he didn't get any worse, and he was taking his bottles, so they said that was a good sign that he was okay enough. They felt happy to discharge him, but they discharged him to the children's community team, who I could ring if I had any worries or if things changed over the weekend. That was Friday evening. I'm not sure what's scarier, taking your baby into hospital or taking him home again. I stayed up all night with him. He stays in my room, so I could keep an eye on him. I was still concerned about him the next morning, but the children's nurse was brilliant. She called first thing to check how he was, and she made an appointment to come see him. They did a few checks and everything was normal, which was a massive relief to me and really helped to reassure me. These things change so quickly. Obviously, we spent the whole of Saturday watching Joseph, and luckily by the Sunday he seemed to be much better. It really made a difference that I wasn't just going home on my own, but that I had the support of the nurse and I could call her.
Thank you, Rhiannon. So do we have any immediate thoughts and reflections from governing body on that patient story? Okay, so I have a few. First of all, bronchiolitis RSV infections quite common, picks up at this time of year and in the spring, so we see more of it. In that, I thought there was something about managing the risk of how a baby was. So those of you that are parents, even those of you who are GPs and see lots of bronchiolitis, will know if your own kiddie is young and starts to breathe rapidly, it's quite angst creating, and it's always useful to get a second opinion. You need a lot of resilience to stay at home with a kiddie if they're a bit breathless, even if you deal with it on a day-to-day basis. And what came out of the story for me was the reassurance that was given and the follow-up, which gave the continued reassurance, because in the past we've seen kiddies go into hospital, come out fairly quickly because they're stable, and then over the next day or two they deteriorate a little bit or go backwards. So I thought that was a really positive development. And I think the other thing is the reassurance, which wasn't quite relaxing. Hospitals never really are, but gave some comfort to the mother and family of young children in our new children's assessment unit. So I'd, once again, any thoughts, anybody wish to add to that? Chris?
Yeah, thanks for that. That was a real insight. It's interesting, isn't it? Because after the pandemic, we've seen a real increase in RSV and other respiratory infections, because we've got a whole, you know, every child under 2 hasn't really been exposed to these viruses because they've been in a sort of lockdown scenario. So actually, we've got quite a vulnerable young population in Barnsley to these sorts of viruses. So it's really important that we get the treatment and pathway right for these conditions.
Mark?
Yeah, I think it also demonstrated the usefulness of a facility where you could observe over a fairly prolonged period without necessarily admitting. It's much more flexible, isn't it?
Yeah, because what might have happened before is if they'd come to the GP and we'd have thought that the baby wasn't too bad, then the mum's got to sit through the night with them, and it usually, or can often, end in a call for an ambulance and turning up at A&E and then being admitted. So this is a useful facility, and the follow-up. Okay, I can't see any other hands go up. Okay, so thank you for that, Rhiannon. Thank you for that patient story. And we'll move on. Can we move on to item 5, declarations of interest relevant to the agenda? Are there any additional ones anybody wants to share with us, or anything that's new since the last report? No? Okay, we'll move on. So I've got patient and public involvement activity report. Kirsty.
Yeah, so this paper's here for assurance. It's our regular overview of some of the engagement involvement activities that we've been doing over the past month, and a bit of a heads up on some of the things we've got coming up. So a couple of items on here that I just wanted to bring to your attention. So we've talked previously about the work that we're doing on the all age mental health strategy. That's picked up pace now. We've got some really good involvement from local groups, people who've got lived experience of mental health issues, and they're contributing to how we design that engagement activity, as well as helping us reach out to lots of areas of different communities to get their feedback. So that's positive. That will be happening over the next few months, which I'm really pleased to see. I also wanted to just give you a heads up that we're doing some work on the all age autism strategy for Barnsley. So that will follow a similar approach, and it's taken its guidance from some of the national development on the national autism strategy. So we'll be replicating some of that activity in Barnsley. We're also working on the neuro rehab services. So as part of the review, we've been working with the charity Headway, who work particularly with people with a brain injury, and talking to people who've used the service in the past, and talking to friends, family, carers, looking at that wider support network of people who've needed to use the neuro rehab services. So that's been really helpful, and thank you to everybody that's fed back into that. And then finally, the children's assessment unit. So we've obviously just heard the patient story, and we've got the paper later on the agenda. And you may remember a while back where the hospital and quite a few actual partners and stakeholders were involved in getting families, young people involved in design and understanding, what was important to people when they came to visit a unit like that, what was the benefits of those units, and describing what that might be for those individuals and families, and helping us translate that back into the design and the pathways that take place in that particular unit. So quite a lot of work to review in this report, but really positive. And again, thank you to everybody that's fed back and contributed and made an impact on some of the decisions that we'll be making. Thank you, Chair.
Thanks, Kirsty. Any questions for Kirsty? Okay, thanks, Kirsty. We'll move on to 7, questions from the Barnsley public. I understand none have been received.
That's correct. We've had no questions.
Okay, so can we then move on to item 8, minutes of the meeting of the 9th of September, and they're here for approval. Are we happy to approve those? Are there any points of clarification or anything anyone wants to bring up? No? Okay, so we can approve those, and we move on to item 9, the matters arising report. And we look at the completed and outstanding actions. Still trawling through the minutes, they seem to have been quite long. Yeah, so matters arising report. Most of it complete. Any issues anybody wants to pick up with the Matters Rising report? No? Okay, that's good. So we move on to a series of reports and assurance reports, starting with 10, please, Chris, Chief Officer's report.
Thanks, Chair. Good morning, everybody. So just on the Chief Officer's report today, we've got a summary of the governance development progress for the formation of the South Yorkshire Integrated Care Board on the 1st of April 2022. So I'll just give a quick summary and then I'll just take any questions anyone's got. So in terms of the summary, then it's obviously this is all subject to legislation in Parliament, but the assumption we're all making is that CCGs will cease to exist March 21. An integrated care board in South Yorkshire will form to take on the functions of the 4 CCGs in South Yorkshire, with some other additional functions around primary care, specialised services and regulation from NHS England. A key part of it is we've set up a development steering group, which involves all the clinical commissioning groups and NHS England. With national guidance is being issued at a pace now, so we've got many documents which we're going through methodically, trying to make sure we're doing proper due diligence to make sure a smooth handover of the functions. National guidance to support the establishment of statutory integrated care boards was published in August, so we're following that guidance, and it includes the functions and governance of an integrated care board and how a model constitution of an integrated care board will work as well. The next step is to appoint designate leaders for the Integrated Care Board. So we have a chair who's been appointed. A process has been underway for last month or so to appoint a designate chief executive. We're expecting an announcement on that in the next week or so. And then we would expect further designate appointments to be made, particularly to Director of Finance, Medical Director, Nurse Director, and then also work out the composition of an Integrated Care Board and how providers and other partners will be represented on that. CCGs are actually legally responsible for the ICB constitution. So myself as accountable officer and the other accountable officers are working with NHS England to start working that up. We're just awaiting some further guidance on that, but obviously we'll bring that in due course through our governance in the CCG to make sure we're fully sighted and fully assured that everything is done as we would expect. Just last point, there's expected there'll be engagement with appropriate partners on the key components of the Constitution, and that's expected to be completed by the 30th of November 2021. So we're just waiting to go through that as well. So in terms of today, this is really just for an update today. So I'm just asking if you can just note the documents in front of you and note the progress to date, recognising there's much work still to be done. Obviously, if you can just note the key activities in Annex A, the published guidance as well, if we can just consider and note that. Obviously, the legal responsibility for CCGs to oversee due diligence and also to oversee the formation of a constitution. That's something I'll have to work with you as governing body members over the next few months. And note the steps to engage partners on the constitution as part of that process. And then the other thing just to mention is one of the big priorities will be to recruit 2 designate non-executive directors. The reason that's so important to do that early is because you can't do the board composition and the remuneration and other things without having a proper non-executive representation. So that's an absolute priority. I was expecting adverts to go out for those 2 posts early November was what I had, but we sit here on November the 11th. I've not seen them yet, but I would expect them to be imminent in terms of adverts. And the other thing is just to know, which I mean we've discussed this before, but obviously the boundary change means that we're currently in a South Yorkshire and Basset Law system. From the 1st of April, Basset Law will go to Nottinghamshire and we will be in a South Yorkshire system. So just for clarity, that's Rotherham, Doncaster, Barnsley and Sheffield will form an integrated care board for South Yorkshire. So a lot in there, Chair. I'll just stop there and see if there's any questions.
Yeah, so Chris has included there, he's done the governing body ask, but included in there is Appendix 1, which has a number of annexes that go into quite a bit more detail about the ICB constitution and proposed changes. Are there any questions for Chris? And just to say really is that obviously our
audit committee and our governing body, well, this will be an ongoing process where we'll be fully involved and engaged in making sure we deliver our duties to form and do the due diligence with the process.
Yeah, we've got those transition governing body development sessions, which are for the transition and change as well, where we'll have more opportunity to discuss things as they come up. Are there any questions that anybody wants to ask Chris today in governing body? No? Okay, thank you, Chris. So we'll move on to item 11. Please, Jamie, COVID-19 update, and I'm sure you'll update us on the recent Health Secretary's advice regarding mandatory vaccination as well. Jamie.
Yeah, I'll briefly cover that, Nick, because that came out obviously after the paper were prepared.
Everybody seems to have a bit of a cold this morning.
Yeah, I know. I've
just had the flu.
Well, it's got a croaky throat, so please excuse me. So in terms of the COVID update, I'll keep this relatively short because we're sort of brief regularly around this area, aren't we? But two key areas: one just on the current position in response to COVID, and then the second, an update in terms of the vaccine programme. You know, as always with these papers, the numbers change between when the reports are presented or put together for you and when we're presenting. So they are based on, particularly in the section around case rates, the numbers are based on the period up to the 24th of October. So there has been some change. So up to that period, we'd still got a very high case rate, the highest in Yorkshire number. That has reduced a little bit. So we're reporting 548 per 100,000. The latest is down more under 500 now, and has been reducing for the last couple of weeks, but it's still relatively high. And likewise for the over 60s case rate, which was above 400, that's now below 350, but again is reasonably high. Continue to see a high number of cases, but decreasing week on week, so that has fallen for the last few weeks. In terms of who are being infected and the highest numbers, so the biggest proportion of cases continues to be in the under 20 age group, so most within the 10 to 19-year-olds, so still seeing increases and high numbers associated with schools. Again, common theme, you know, that is reducing a little bit. So I think as schools have got back and started to sort of get involved with supporting their children and people have isolated, that number has reduced somewhat. We're seeing a number of outbreaks, so there's no numbers in here, but some of our care homes have had patients who have been positive with COVID, and that plays through in terms of some of the booster vaccination for some of our care homes, which have had to be just delayed slightly, or for some patients delayed because of the numbers, and continue to see some in other care settings as well. That's affecting staff as well as it is patients. So in terms of healthcare, continue to see the system pressures. There's still, whilst there was some relaxation around infection and prevention control measures that needed to be in place because of the high infection rates, that continues to create some really tough situations, particularly over the last few weeks in hospital, where they've had to create additional COVID wards just to keep people separated. In terms of the cases in hospital, that continues to increase. So slight change in the pattern here as well. So 90% of the people in hospital are over 50. So that's still that sort of older end of the population, and you know the median age there 73, but a wide range from 30 right up to 90. The interesting bit, 80% of people who are in hospital now have had both vaccines. 2/3 of the people who are being admitted to hospital or were in this period were admitted with COVID symptoms. So not just people that are in and having tested positive, people poorly with, and 24% of people that are in with COVID are needing ITU. So we've been up in the sort of 60s for the numbers in hospital. So 15, 16 in ITU, which is sort of where we were right in the middle of this. So I think we're still seeing a lot of pressure there. Likewise in primary care, so demand continues to be really high for the COVID clinic. There's over 400 face-to-face appointments happening there. It happened there. September's the latest I've actually got, but I think it continued to increase into October. That was as high as it's been throughout, and the home visiting service supporting practices 300 plus home visits each month as well, with about 40 or so into care homes. So a lot of activity there. And then the iArt service, extended access, that's continued to operate 95% utilisation, and that's despite us increasing the capacity in that service. There's around 20% more appointments now than there were in April 21, but still extremely full, so we can see the demand continues. So that's the sort of pressures, demand and case rate. One of our biggest tools, I think, continues to be pushing forward with the vaccination programme, and whilst, yeah, we are still seeing now people that are double vaccinated in hospital, I think the feedback and the scientific evidence is still that the vaccination programme is reducing the impact, is preventing some of the, or reducing some of the spread, and is stopping some people becoming as ill. So continue to do really well on that. So I think the report says 290,000 vaccines done in Barnsley. That's up to 296 now. I think there were 1,200 done yesterday. So we keep seeing increases and lots of activity going on there. 400,000 vaccines for Barnsley residents, if you take into account those that have been vaccinated either in the hospital hub or at another site. I'll not go through all the detail of the individual cohorts. You've got the numbers there. The uptake is good, continues to be high. We're about halfway down, I think, fifth paragraph on 5.2, just starts to introduce some information around the new cohorts that came in. So 15th of September, there was an announcement around the 12 to 15-year-old programme. We'd already been vaccinating certain 12 to 15-year-olds, but this were for healthy 12 to 15-year-olds, and it were a programme to be led by our school age immunisation service initially. They now have been, I think, yeah, they will have now been into every secondary school in Barnsley. They've also put on specific clinics for people who are homeschooled or not in school for other reasons. Last couple of weeks, we've now been able to introduce appointment slots in the primary care sites through the national booking, so anybody that's not had a vaccine in school and who wants one can come forward and have a vaccine at the PCN sites now. So they've started doing that. Also on the 15th of September were the announcement around the booster programme. So that's for all over 50s with specific conditions, and people have been invited in at 6 months, or were up until last week been invited in at 6 months, or after 6 months from their from their second dose, so the completion of their primary doses. There's been a change the last couple of weeks where people are now able to book at 5 months, but not for an appointment at 5 months, so they can start to get their appointments booked in front. At the end of October, they've done 32,000 booster vaccines. There's now 43,000 Barnsley people had booster vaccines. There were 11,000, so not all in Barnsley, some have gone to other places, but 11,000 people over that last week and a half who had their booster. So really positive there, and we're sort of again in the pack with our neighbours. So our continued focus is to make sure that through our comms and engagement and work with communities, we encourage the uptake of that booster. It's really important, but also that we acknowledge there's still a fairly significant number of people, mainly in the younger age group, but even some in the over 80s, who have not had a single dose of the vaccine yet. So continue to reach out and do that and push that message to drive that up and try to continue to do. And then the final point on this paper, just to make, and it doesn't have a big impact it doesn't have any impact in that sense for Barnsley, but through the COVID vaccination programme, there's been a number of different phases. We now moved into phase 3, which is around the booster and then continuing with the offer for firsts and seconds for those who have not had or are due to have. There was an opportunity for GP practices and PCNs not to opt into phase 3. In Barnsley, all of our practices opted in to continue to work with the model that we've got. So we continue through our PCNs with the support of all our practices to now move into phase 3, which will see the completion of the booster programme, or this part of the booster programme at least, and we can also continue to offer them first and seconds. So that's all I wanted to cover on there, but I'll take any questions that that people have got. I'm sorry, I'll come back to Nick, your point around the Corvid vaccination. So that's on the back of, there were a consultation, so it's not included in the paper, consultation on whether it should become mandatory for health and care workers, to frontline health and care workers, to be vaccinated. So this is much the same as it is for those people that work in care homes. So a little while ago now, everybody that works in a care home or works in another setting that enters a care home to deliver their duties were mandated to have the vaccine. Can't off the top of my head remember the date, but it might have been today. It was a date in November that everybody had to have had that point. It might have been the 11th. Following the consultation, that's going to be pushed out. So all frontline health and care workers will be mandated to do that. So there'll be a piece of work, and I don't think it's concluded, but there'll be a big piece of work now to understand the exact position in terms of all of our frontline health and care services. What are the numbers that are involved there, and how can we support those people to access the vaccine? But that could cause obviously some more pressures on all providers if we've got numbers of staff that have not had their vaccine. From the care home work, it were relatively small, so it didn't cause a big problem. Small numbers of people not vaccinated who were staff in care homes. So hopefully we'll see that same pattern through the rest of the health sector. Thanks.
Thank you, Jamie. So any questions for Jamie? Okay, I've got a couple, Jamie. I think the first one is, if by now most healthcare workers will have had lots of information about the COVID vaccines and lots of opportunities to have it. So some of those that don't want to have it may have very specific reasons, others may have other forms of objection to it. Given that we're struggling for capacity in the healthcare system, is there a plan for those people who continue to decline to be taken off frontline and perhaps used in another capacity?
I think that'll be down to the individual providers, Nick. So I've not seen the detail of the guidance that's come out. So there'll be exemptions, but they'll be clinical, as I understand. And I guess each provider will need to work through whether they can do that. There might be people in certain roles that it's essential that they continue in that front line, and therefore that causes an issue. But I'm sure that's something we can pick up through the partnership as well, just to sort of encourage that, because we should be looking to retain whatever resource we've got and maximise the capacity. And if that means we can move around, then that'd be great. But there might be occasions where I suspect that's not possible.
Right. And the second thing was, could you give us any update on where we are with the flu vaccination programme?
Yeah, I'll give you an update on flu vaccine. I've not seen the latest numbers, Sonny. Can I ask a favour of the governing body? If whilst we're working through, I'll just get the latest uptake numbers, and if we can pick it under any other business, then I can give you some of the flu uptake numbers.
Yeah, yeah, that's fine. I didn't mean to spring it on you. I just thought the public should know it started, and people are getting the flu vax. Yeah. And we're trying to do them together where it's possible. Yeah. Yeah,
it has commenced. All practices have been delivering their flu clinics. A number of practices have seen uptake higher than what they anticipated based on previous years. So there's central vaccine available that can be drawn down, and I know a number of our practices have requested additional vaccine for that. We've got, in terms of just the headline, not actual numbers, but what I'd seen before I was off, as usual, the sort of over 65 cohort is coming along fastest and the uptake has been quickest. The area that is more difficult and that takes a little bit more engagement is the sort of smaller 2 to 3 year olds, and encouraging parents to bring in that cohort. But everybody is on with delivery where possible. They've done some co-delivery of the vaccine in care homes, working with pharmacy and other colleagues as well. So when people have had their booster, they've had their flu vaccine. So it's on track. Everybody has got their vaccine, and every practice has got their vaccine, and the clinics are moving through. But I'm sure Mark might be coming in around progress, but our primary care colleagues will know where things are at in their own practice. But I will just get some numbers for the end, Nick, and then I can just share some of that back.
Yeah. But I think you've given us a significant update anyway, Jamie. I think Mike had his hand up first, then Mark. Mike?
Yeah, I mean, thanks, Jamie. I mean, I think that reflects all the hard work you and the team have been doing, and it's been working very well. I mean, my question really is, various areas of the NHS and the care system are hanging on by its fingernails. As Nick says, everybody's had the information about the vaccines, and presumably those who haven't had it don't want it and will therefore be out of a job, probably going to a better paid job at Amazon or somewhere in April. And are we going to build up plans to backfill those, because otherwise the system's going to collapse, isn't it?
Yeah. I think our first job is to understand the numbers, and that would seem relatively simple, but not all health and care workers are sort of registered with their GP practice as that. So hospital workers, we know, and the hospital will be able to work through that. But some other health and care workers who might be covered under this are not. So we need to work with all of our partners to understand the numbers, and then we can assess the scale. But yeah, it's going to be a sort of fragile position to be in. So we'll do what we can.
Yeah, I mean, just to finish, I think it makes good politics, isn't it? But it's not very practical sometimes.
Yeah, it is interesting. I heard on the radio from Scotland that they've managed to do, without it being mandatory, I think 99%. So different approaches yield different dividends, but populations are a bit different as well. Thank you. Mark?
A couple of things, really. I mean, as far as our vaccination with COVID with staff, wouldn't expect a problem with that, because all hours have already been done. Coming back to the flu, our over 65 uptake is quite a bit less than we were expecting, and we wondered if the delayed delivery has led to people going elsewhere for it. And I'm not sure how quickly information is coming through to us about where else they've had it, but at the moment we're a bit down.
Right, so I was just looking at the numbers, Mark. So I can't see. So we might be able to get into that. So on the data that comes through to me, I can't see where people are having their vaccine very easily. In terms of the 65 plus, though, the current position is at just below 70%. So 70% of people, Barnsley residents, have had their vaccine already. Obviously, the ambition is to be higher than that. I don't know what your local numbers are, but people are going and getting it. It may be, as you say, that people are going to pharmacies or others that received some of the vaccine earlier and were able to give it there.
Okay, thank you. John? You're muted, John. John?
Yeah, I've got the figures here for week 43. It's I did have them. Hang on. And it's about 69.5% over 65s across Barnsley. Under over 50s is starting to pick up. I suppose that's right, since we may do 2 clinics for over 65s and over 50s. And children is low, but again, that's usually the last group that get it done, the nasal ones. And then that, and only 26% of vaccinations so far being given out in the pharmacies.
Okay, thank you for that, John. So we've had a bit of live data coming through today, which is different to the usual governing body, but thank you for that update. Can I move us on then, please, to item 12, which I think is you, Jamie, urgent and emergency care update, including at Appendix C, the winter plan.
Yeah, and again, just noting that this is an assurance paper and aimed at providing assurance to governing body around our urgent care programme. I'll try not to get into too much of the detail, but just take people through where things currently are. So in terms of the CCG priorities that are set out in our governing body framework, there are 7 of those that range from increasing clinical assessment and the use of 111, promoting 111 as the best way into services, delivery of A&E standards, utilising direct referral from 111 to other hospital services to avoid ED, enhancing same-day emergency care, so our ambulatory care facilities and others, patient flow, and then the rollout of a 2-hour community crisis response service to, again, provide a community alternative to A&E. So they're the 7 areas. Over the last 6 months, we've continued to see the impact of COVID. We've seen increases in terms of the pattern, and I'll come on to that in the next section a little bit further. So in response, the Barnsley Urgent Emergency Care Delivery Board developed a plan. We had a session with a governing body, development session on some of that after I did the last assurance report. Some things have moved a little bit on that. We've been working with NHS England, improving urgent and emergency care team to identify opportunities and areas where we can make sure that people who need ED get there, but those who don't can access alternative services, and that we've got all of those pathways in place. And just into section 2, just share there the activity levels that you can see from the 2 charts that are included, that A&E attendances are above now anywhere where they've been in the last 5 years, and have been sort of at that top end throughout. And likewise, non-elective admissions are right up along that sort of top line, and we continue to see that. Obviously, in 2020, we saw a bit of a reduction, which then led to a sort of fairly steep rise. We're not seeing that continued increase, but neither are we seeing any reduction. So things have got to that level and are stable there. So just going across to the next page, I just wanted to sort of highlight this, and apologies, Chad, noted on the front of the paper, because it's an assurance report, it were down for assurance and information, but there is a bit here that I just wanted to ask governing body to approve, and we talked through some of this at Finance and Performance Committee last week. So the CCG received 1.53 million of capacity funding for the second half of the year, and Roxana might come in as well if we've got any questions on this. That came with one commitment, so a pre-commitment from the first half of the year, which was around 111 first and promoting that. The cost of that to us is 164,000, leaving 1.369 to support place with our winter plan. We had some discussions through the Urgent and Emergency Care Board around that, and we'll come on to our winter plan later. We know that in other parts of the system, there's additional capacity funding, winter access funding to support primary care and other areas. And in the conversations, we identified that pressures within H2, particularly at Barnsley Hospital, have meant that they would be unable to cover the additional costs that they'd be expected to see during winter. and therefore as part of our financial plan and this proposal, which I would like governing body to support, is that the 1.25 million is allocated to help to offset and manage those increased costs, but that we retain a small amount, 119k, to mitigate any future pressures, and we hold that for the Urgent and Emergency Care Board to identify where that could potentially be used, but obviously would come back should we need to ask for a governing body decision. So I don't know if you want me to pause there for if anyone's got any questions just around that first bit before I go on to the urgent care plan.
Yeah, we could take the approval of that funding at this point before we move on. It's an ask of governing body. What I found interesting though, Jamie, was so I wasn't at Finance and Performance, was we're giving money to the hospital, but what are we expecting to see for that 1.25 million? Because it is a hospital, almost a unilateral, it's almost going all to the hospital. So what do we expect to see as an increase in their performance as a result of this?
Yeah, so I think the main
I'm cognizant of the fact that investments in other parts of the system some have come with various asks, so I just wonder what we would expect for this. I'm not debating the investment, I'm just debating what we would see.
Yeah, no, that's fine. I don't know, Roxana, do you want to come in first?
Yeah, so it's covering the cost of the increased activity over the winter period within the hospital. So I think in terms of what we'll see, it's funding the cost within the hospital to provide the additional activity that they've included within their operational plan. So essentially that's what it would fund. So there won't be any other sort of reporting requirements or anything like that. It would just be funding those increased costs, which will include an increase in their agency spend, bank spend, etc., because of staff sickness and staff turnover and issues around staffing that they've got in the trust. So that's essentially what it would support.
Right, so it's supporting ongoing expenditure during difficult times, but are we asking a reduction in any waiting time or any new pathways or anything to be accelerated or anything around the elective re-establishment of elective figures, or is this purely for the things you've outlined?
Within the hospital plans and within the winter plan, when this will be tested, and I think it'll be tested a number of times, but there's an ambition to maintain elective activity throughout. So normally in January we'd be closing the T&O wards. They're aiming to be able to do that, but to do that they've had to open additional winter capacity elsewhere in the trust. So we would be expecting them to try to maintain and deliver against the planning commitments, which is to continue to reduce long waits for elective care alongside the non-elective and A&E activity. In terms of A&E performance, we know that has been challenged. The hospital board are very, very focused on trying to make sure that is driven up. So whilst we've not set a specific target to do that, we would expect that any impact would be minimised by making sure that they've got the appropriate staffing in place. We'd also, as we work, and we've talked around this, and it's included in the plan as we come on around the sort of streaming model and bringing that in there, we'd also be working with them to make sure that any additional costs associated with that are covered, to make sure that they've got the right model at the front door as well. Yeah,
and I think that streaming would be one thing that we would be able to point to this funding and say a contribution of that. It's non-recurrent funding, but we need here and now.
Let's get it in place. Yeah.
Okay, thank you. Thanks, Roxana. John? You muted, John. Muted.
I get confused with this because the hospital are being funded on activity based on, is it 1920? Which is large amount of money they've been getting based on those figures for that year. And yet they've reported a deficit of £3 million this year, the only one inside Yorkshire to do so. So unlike Nick, you know, what we're going to get for this money and how we're going to monitor it that we do get it, because are they just going to use it to offset their deficit or increase their financial position? And that concerns me, especially when Roxana said last time, we may have a financial position, but we're overcommitted by 25 million. So I don't know where all this money is going to come from.
Roxana, do you want to quickly respond to that?
Yeah, just so this is non-recurrent, so this is not funding it on a recurrent basis. I think it's important to note that. I think it's important to note that there is lots of work, and we did discuss this at Finance and Performance Committee about how we would take forward, I suppose, financial sustainability of Barnsley moving forward. And that's going to prove to be a, you know, fairly challenging conversation to be having, isn't it? Because we're going to have to get into the crux of what everyone's cost base is, and a very open and transparent conversation. So I think we're kind of almost in kind of trying to treat the two as two very separate things. We're funding this year to try and get through one financial year, recognising we've not had the conversations we need to have to be able to take costs out of the system. So I completely agree that we are just funding costs, but I think we need to recognise that there's lots of work we need to do to be able to get to the point where we're taking costs out.
Okay, Mike?
I mean, I accept what Rax and Jamie have been saying, but it does seem to be every year we get this thing where we just pour money into a system that doesn't seem to be, the underlying model doesn't seem to be working, and whether we can steer this money towards things like streaming, things like the community crisis team, which would stop patients ending up there in the first place, and therefore use it as a way of changing the model as a pump priming method.
Yeah, I mean, I think we Roxana, you've had the conversations with you know, the hospital around from a finance perspective, and operationally through the A&E board, we absolutely want to make sure that things are in the right place. In the community crisis, we've got the resources there, and we've got agreed investment in that, Mike, so that's there. But definitely the streaming, the front door model, making sure that we're accessing the right alternatives is going to be crucial to this. Just picking up, so obviously, John, I know you made reference to the 1920 levels, but I think we got to note, actually, the activity levels for non-elective and A&E are above 1920 levels, so they might have been top up and other things, but they are operating above that. And when they're opening up the COVID wards and other areas, they've got the space and the costs, but they've got many less people on each of the wards, so the cost of them covering, because of the IPC arrangements and things in place, do bring with it some additional costs.
But Jamie, didn't they apply for COVID funding for those extra costs? Because in the back of my head, I've got a thought that they actually applied for more than they should have done. For
H1, I don't know, in H2.
Yeah, there was a bit of a recovery fund, wasn't there?
Yeah.
Regardless, I think that if I think we could probably support it, but I think take the comments on board about where these monies might, as non-recurrent, and Roxana's point about money flow through the whole system will be a big, but the appropriate ask and task for the future.
Okay, thank you.
So we're agreeing to support that proposal, and we've said that, you know, our observations and comments should be taken into account. Yeah. Do you want to take us through the rest of the paper, Jamie?
Yeah, just quickly, because you've got the papers there, and hopefully people have had an opportunity to read them. So in terms of the urgent emergency care plan, that sits within the sort of context and underneath the overall Barnsley plan that's been previously discussed and presented to governing body. Key area for urgent emergency care, whilst there's a number in there, is priority 6 around responsive and accessible care in a crisis, and there were 3 initial priorities identified around comms, that front door navigation, and clinical standards in A&E. There's 3 additional sort of key deliverables that have been identified as we've worked through some of the information with the hospital and the improving urgent emergency care team. So they're around DOS and alternative dispositions, making sure that all of our services are appropriately accessible to urgent and emergency care providers, so whether that be 111 or ambulance. The development of same-day emergency care pathways, so there's a lot of work gone into that in hospital, but actually are there some outside of hospital, such as community response, that is now there, but have we got the right access into it and the pathways into that, and then aiming to be as prepared as possible for winter. So on the Barnsley plan, I've shared as appendices to the report the urgent care logic model, which just takes people through the work that we're doing, the key activities and the expected outcomes. I'll not go through the detail of that, if people have had a chance to see it. And then in terms of the assurance element, we're reporting this now on a regular basis through the integrated care partnership. So you've got a copy of the highlight report that just sets out the current position and progress against each of the key areas of work. So that's the plan. And then I've also shared with governing body a copy of the Urgent and Emergency Care Board winter plan. So we try to pull this together each year. I think it's always important to recognise that this plan is not an organisational, operational plan. The hospital have got their sort of detail of what will happen in terms of staffing wards. Swift have likewise, and all the business continuity. So this is to just try to pull together and look as a system at what more we can do. And included in the plan, we've just tried to map out the additional areas, the additional capacity that is being put in place, and working through the process is quite interesting how much extra actually there is in place and being put in place to try to support. And I've set that out against sort of 4 areas. So the first around preventing or minimising urgent care demand. The second bit is around accessing urgent or same day capacity. Then the treatment, so inpatient people who do need to go into A&E and who do need to be admitted, how do we make sure they get to the right services and are discharged in a timely manner, which then comes on to the 4th area around the discharge and out of hospital support. And there's a number of things set out in there that are being done. So that's how all I wanted to present to governing body. I hope that provides some assurance that, you know, we are really looking into this and trying to push as much as possible, and hopefully the things that have been put in place will help us with the increased demand over winter and into next year. I'll take any questions. Thank you.
Any further questions for Jamie? No? Okay, so the governing body, we've been asked to note the update on the current position and plans on urgent and emergency care. We've done that. Note the Urgent and Emergency Care Board Winter Plan 21-22. We've done that, and we've agreed the allocation, the proposal to allocate the funding. We've discussed that. So thank you, Jamie. Can you then take us on to the next item, 13, Assurance Report Primary Care?
Yeah, no problem. I need somebody to fetch me another glass of water. Yeah, no, that's fine. So Julie passed an apologies. Julie's on holiday been on holiday for the last couple of weeks, but prepared this report to provide assurance against the key areas that are included in the governing body assurance framework in relation to primary care. So they're included in the introduction and background section. Within the discussion points, there's a focus on sort of 2 key areas. So one around progress with long-term plan commitments, and then the second, an update around obviously the network contract, DES and PCNs. So just in terms of the first, so long-term plan, there's a number of areas identified here that have been worked on by the team and across primary care. So first is around access activity. So we'll know this because we've talked about it before, but the access demand continues to be exceeding capacity. So we continue to deliver the OPT clinic, and that remains in place for all face-to-face assessments where any COVID positive or suspected COVID symptomatic people can access services. We've also continued to maintain the COVID home visiting service for those who are too poorly or unable to attend that clinic. Appointments within IART have been flexed to meet the needs. So we've had more appointments put on. I mentioned that in the previous report, 20% more appointments that are in place. So that's in there. Also under access, there's a reference to telephony. So we know that there's some challenges around telephony and people getting through. So just a reminder to governing body that we are supporting work in 2 phases initially, to upgrading the lift buildings to a sort of cloud-based technology that allows better access through phones, and then the rollout of that to the remaining practices, which will hopefully commence within the next month. So that should enable improvements to telephony services. I think we will continue to have some challenges around accessing that. When we open up the lines, we need to look at how we support people being able to answer them phones, and when we're referencing some of the challenges around staffing, how we do that. And it's not referenced in here just because of timing, but some of the thoughts around the Winter Access Fund that were announced by NHS England is that there could be potential to offer some ways of supporting that telephony function and the call answering functions, but we'll pick that up at a future discussion.
Sorry, James. Hasn't there been some disquiet over the cost of the telephony in the lift centres?
I think there were a discussion around that, John, but I think we've had a conversation through SMT and shared back out to practices that actually there isn't going to be an increase. We'll continue to support with a much reduced cost, but we'll continue to support with that. So practices in lift buildings shouldn't see any difference. And I think that's helped to sort of move that along.
I only say that because I only found out from emails written by my colleagues about their disquiet over this. I never received an email about telephony and for Cudworth, so I was a bit lost wondering what it was all about.
I believe it went to SMT a couple of weeks ago, John, and I believe that's been looked at and the issue's been satisfactorily resolved for all practices. So that was good work that was done. Chris, do you want to come in and ask Jamie something at this point? You've got your hand up.
I just want to follow through with what John said, and I hate the word cost. I would put that in the area of investment, because one of the major frustrations that we've got, as you quite rightly know, is the ability to get through to our operating locations. So yeah, there is a word called cost, John, but I see it as an investment in going forward, really. That's all
I don't disagree with that, but where's this investment coming from? If it's coming from the centre, then fine. And the other thing, you keep saying having difficulty getting in. Come and sit in my practice, right? I can't even get into my receptionist from my phone in my office because the phones are engaged and everyone's phoning. And there's the numbers of phone calls coming through. It's not that we're not answering them. It's just that we haven't got them. So really, I really get annoyed when people say they're having difficulty getting in. I'm having difficulty phoning from my room to the reception because they're engaged. Yeah.
So I think
okay.
So I think it's factually correct. Factually correct that it's difficult, though, isn't it? But it's difficult not necessarily for the reasons that people think. And I think that was my point right at the beginning, that the demand and the calls is potentially exceeding the capacity to answer the calls or for other things. Yeah. It's not that people are sat listening to them ringing. I 100% understand that.
Yeah, and I think we have to be careful about understanding what's going to help us in this current crisis and what's going to help us in the future. Yeah. And in the current crisis, with some slight reservation, whatever wonderful phone systems you put in, you need the trained staff at the other end to pick up and to know to which member of the staff to assign that piece of work. Yeah. And the problem is that our staff have faced COVID illness, isolation, bereavement, some frustrations from patients which have boiled over into abuse at times. Some frontline staff, receptionists particularly, have left or have reduced hours because of that stress. And actually training up high quality staff in these circumstances is difficult. So I think it's a balance, but I think in terms of improving phone systems, it's definitely an investment, and we need to do the maximum we can, both in crisis and going forward. Okay, so one last point, Chris, then we'll move on.
Okay. What springs into mind immediately, Nick, is the good training that we did, where we put the description of first port of call. Because you quite rightly, I've been involved in call centres, and unless you get the right training, the right words, you end up arguing rather than signposting. And it comes back to my word within my world was, no, we haven't got costs, we've got investment. So it's giving the people who are picking up those phones at whatever time the tools to be able to navigate in the right way. Vitally important.
Okay, thank you, Chris. What we'll do now is we'll ask Jamie to move on.
Yep. Okay, thank you. So just taking us through these quickly then, the Practice E declaration, so that's for practices where we confirm they're compliant against core contracts. So all of our practices have done that and confirmed compliance. They'll be reviewed by the team, but we've got that position. Likewise, all practices signed up to the network contract DES to continue working with Barnsley Healthcare Federation to deliver the specifications there. I'll come back to that in a little while. Continue to invest recurrently into primary care in line with previous agreements. So that is allowing us to, or total investment enables the CCG set a guaranteed and consistent income level for practices. So that continues. There's been some work around E-Consultation, and this is an area that is increasing in focus. As NHS England and the government talk about access, how can we make the most of E-Consultation? So we've worked with others across South Yorkshire, but secured access to AccuRx software for all of our practices to be able to use, and that can support online and video consultations. The uptake, it says uptake of practices. I think most have got the systems, but whether we're maximising the use of and doing the video consultations and things, that might have been a little bit slower, or we've used telephone instead. So again, there'll be some work by the team and hopefully supported by the South Yorkshire plan to use the access funding to help get the most out of E-Consultation. Social prescribing. So My Best Life service continues to be in place. That contract does come to an end at the end of March 2022. Obviously, social prescribing and the requirements around social prescribing sit within the PCN network DES. So there'll be a period of sort of handover and transition where there'll be an expectation that the PCN pick up the offer and deliver a social prescribing service for all ages as we move into next year. That conversation is just beginning, but we will continue to have access to a service that GPs can refer into. There's a little bit around quality improvement support. Julie works with Madwi and others around the quality dashboard that is shared to practices so that they can use that tool to try to identify areas for improvement and improve quality. So areas such as infection control, prescribing. And then the final point here, which sort of links into the PCN as well, is around the primary care workforce. So whilst we know there's challenges around the workforce, and that risk's been reviewed by the Primary Care Commissioning Committee in relation to additional role reimbursement and making sure we're supporting the Spec. The workforce plan for 21-22 was submitted at the end of August, and that did show full utilisation of resource to recruit this year. Primary care team have worked with the PCM managers to review the recruitment against trajectory, and when there's any sort of deficit, look at how we can do that differently. And a workforce plan has been submitted now for it says on here is due imminently, but it has been submitted now and looks at the introduction of more roles next year. And then I'll assume people have had opportunity to read, 'cause it's relatively short, but the section on primary care networks around plans for 21 and 22. I've just said the workforce has gone in. We've notified PCN around regarding the sort of impact and investment fund and additional role reimbursement, so they know the key areas. 5 areas of focus over the next 18 months, which are set out in the bullets there. So preventing and tackling health inequalities, supporting better patient outcomes in the community, supporting improved patient access to primary care, delivering better outcomes for patients on medication, and helping to create more sustainable NHS. So they're the things that are set out in the DES requirements for next year. Does reference in there that we're doing work with the PCN in anticipation of future specs. So the full health inequalities spec, personalised care, anticipatory care, and also some of the sort of clinical indicators that come. But we know that some of that stuff has been delayed, obviously in recognition of the pressures around COVID. So we'll only start to come in later next year. I'll stop there, I think. Thank you.
Okay, thanks, Jamie. I think on additional roles, we did have a meeting between the primary care team and the GP Federation to make sure that this year there was a realistic plan that went in that would fulfil any potential funding that we would get. So that the whole of that funding, if we're able to recruit, that's the caveat, should be spent. So that was a step forward. John?
Yeah, Jamie, you don't mention disinvestment. I just realised this week that CCG has disinvested in licences for Watch BP. So if that's the case, the practices could turn around and now start sending their patients to the hospital to have 24-hour BP monitoring. And we get several requests from hospitals, anaesthetists, etc., who take blood pressure and say, we can't operate, blood pressure's high. And we bring them back and we'll do a 24-hour BP, and 9 times out of 10 it's normal, and we'll send a copy of that to the hospital for them to get on with doing the operation on the patient. Now, I don't see anything in there where, and I don't remember anyone saying they were going to disinvest. I mean, the only way I know is I got a bill this week, and we phoned the emails up and said, what's this for? And they said it's the license for Watch BP. The CCG no longer will be paying the license. So can someone clarify that? Who made the decision? What thinking was behind it? And as Chris says, that is an investment if we're doing the 24-hour on site.
Okay, you probably can see my confused face that I'm not going to be able to answer you.
I think we could ask the primary care team. Yeah, and see what's happening there.
I'll find the answer to that. I didn't know that, but we will find an answer.
I mean, I'm talking from a personal experience. We do it, the patients are happy. 9 times out of 10, we're able to reassure the hospital, look, this is him panicking when he gets to you, when you're just taking a one-off reading. Here's the 24-hour blood pressure, it's normal. Now, we could open it up and say, fine, we'll refer to the hospital to get 24-hour blood pressure, waiting time, 3 months, 6 months, I don't know. Then wait for the result and then send it back. And I don't know who makes these decisions and whether they actually think about the consequences following those decisions. And what surprises me, I've not seen anything about this in any of our meetings. Chris, on PCC, have you discussed it?
It's not in the, I haven't seen, it doesn't ring a bell with any of the assurance reports we've got today. And I think you've made the point well, John. And I think we'll leave it with Jamie to pick up with the primary care team.
Yeah, I will, absolutely.
So I think we've completed the governing body ask there as well, page 113. Just bear with me a second.
Yeah.
So we're asked to note the information in the report that provides assurance. We've picked up John's point, picked up a couple of other points. So I think we can move on, having noted that. So thank you, Jamie. we now have item 14, assurance report, digital and IT. Jeremy.
Thanks, Chair. So it'd be good to get Jamie's voice to rest a glass of water. So this is the digital and IT assurance report. So it's a governing body's assurance, and to note there are no decisions to be made. I can't believe it's 6 months since the last one either. Time's flown for all of us. It's been so busy and pressured, hasn't it? So there are two parts to the report effectively. There's a table in section 2 which goes through for primary care purposes, completed by the head of primary care, the GP IT programs that are in place and are reflected in the GBAF. And there's an update against each of those areas there. Some of those have been picked up already. So James has already mentioned the AccuRx video conferencing system, for instance, which has been renewed and will continue. No reference in here to the point you just made, John. So Jamie and I will both pick that up as well, just to see where that decision has been taken. Just wanted to spend a little bit more time just updating on where we are with the shared care record. That's in section 5, a bit more detail, the kind of executive summary. Making progress on this. So it's the strategic digital group in Barnsley that's pushing this forward, working with our digital colleagues in the ICS as well. That digital team in the ICS has undergone a fair bit of change over the last few months, and there's now some continuity there, but has been a little bit of disruption as that team has chopped and changed a little bit. Nonetheless, we made some, I think, some good progress, both locally and across our ICS as well. So locally, we've agreed how we're going to fund a digital program manager to help us really get a grip on this and have the capacity and time to move us forward, and in particular to prepare for us an options appraisal around a share care record viewing system, and the recruitment for that post, which is jointly funded by the CCG and BNBC, is currently underway. We're just at the moment in just agreeing the grade and through our grading systems in BNBC to get the grade of that post right. But we're hoping to get that post in place by Christmas, and then obviously working for us across Barnsley from that point onwards. So I think that's a positive development. For some time now we've been held back a little bit by the availability of resource, so we've now collectively agreed how we're going to address that and push that forward. Second thing just to note is that the ICS itself has now committed itself to the Yorkshire Humber Care Record as an overarching approach for South Yorkshire. So that's clearly a technology platform that is established in the Humber and is now being rolled out across a much wider area. And I think at this point, pretty much all our organisations, provider organisations with care records to upload are signed up to that, as well as the ICS itself. So that gives us some clarity about the direction in which we're heading, which is really helpful, and also means we'll be doing the same thing across South Yorkshire as well. So it means that share of care record, the approach will be the same, and there will be some economies of scale in how we're able to deliver that across South Yorkshire and in our places. And not in the paper today because it's only happened in the last few days. For instance, there's a business case now progressing in the ICS to access national funding to really help us to push forward and develop a programme to onboard all our provider care records into the Yorkshire Humber Care Record, so and get that sort of queued up and actioned and ready to go. So I think again that's a really positive development, and I hope that business case will be successful. The third thing is that in Barnsley we're looking to see whether we can get agreement and again commonality on our approach to how we view the records once it's available from the Yorkshire Humber Care Record, how we view it in Barnsley. We'd all like to be using the same system. I think it makes sense to us to do that. We've been looking at two options. One is called IMXCR, previously called Viper 360, and that's we've had demonstrations because most of the healthcare system to this point, hospital are interested to and keen to take it forward. We've had engagement with some of our out-of-hospital teams. BNBC are keen to move it forward for social care. And we just had the first meeting with PCN clinical directors as well. And again, we got some support there too. So we got some momentum behind that particular solution. However, there's another one as well, hence the need for an options appraisal. That was the Yorkshire Humber viewer itself, which so again over the last 12 to 18 months, so it's more mature than it was the last time we thought about it. So we'll want to think about which of those two options we take forward, and that will happen over the course, I hope, of the next financial year, but there'll be a fair amount of work up front this year to get us into a position where I hope we can get that deployed across our places. So that's really what I wanted to say. The other thing just to note is that as part of our work across the RCS2, we do need to meet the kind of minimum viable solution for a shared care record, which is principally bringing hospital and primary care data together as a first stage. Deadline for that was originally September this year. That's been pushed back to April 2022, and that's what we're working with our ICS digital colleagues on as well. So again, we have a consistency approach and a plan to deliver that. So it's a complex piece, I have to say. There's a number of moving parts. It's not all completely in the gift of Barnsley Place itself. We need to be working with our ICS colleagues on this as well. So that's the update for governing bodies and Chris and Nick.
Thank you, Jeremy. Chris?
Jeremy, when will it actually happen, this? Have any forward dates at all?
So I can't give you a firm date at the moment. If the business case that the ICS is progressing at the moment is successful, that will allow us to confirm and fund our approach to onboarding care records into the Yorkshire Humber care record as the first step. Once they're there, we can then have the viewer then pulls it down as required, so that viewer then can be commonly installed across Barnsley Place. We had considered in the past going it on our own, just having a Barnsley shared care solution. Been overtaken by events anyway on this. It didn't make sense at the time. We always wanted to work more widely. Sheffield was our preferred option at one stage. It makes sense to do it across the ICS and make sure we're doing it collectively.
Thank you, Jeremy. Any questions for Jeremy? Any further questions? Can't see any. So thank you, Jeremy. We've got to item 15. Has Jo Haddison joined us? Is she there? I can't see her. Okay, Jo, would you take item 15, please, for us?
I am sorry, Chair. I was just trying to get off mute and back on video then, so I do apologise.
Good, yeah.
This is the report for continuing healthcare and complex cases, reference to individual funding in all areas, really. I'll take it that Chair and members have read the paper, and I'll just direct your attention to a couple of highlights. On page 1, the various committees that the teams report to, and the governance and scrutiny that's in place. On page 2, continuing healthcare outstanding reviews are at 6%, which in terms of numbers is about single figures. And that's a favourable position in South Yorkshire against the other CCG CHC teams. There has been an increase in referrals and eligibility across the board, which will obviously result in an increase in spend and in workload. The team has just completed demand and capacity exercise on that, which I'll dilate on more in private session. There is a market issue that we've highlighted in terms of there's a lack of provision anyway, so it's a provider market, and providers are definitely leading costs, and there seems to be an upswing in a demand for one-to-ones and two-to-one support on discharge from hospitals in the D2A process, and also when someone's newly admitted to a care home, and in some cases we're seeing that in home care as well. And it seems to be around falls and behaviours, but again, I'll dilate on that in private session. There's a bit more detail on that. We're on to the children's continuing care and complex cases on page 2. Just to note the priority areas that we're working on at the moment, and that this is now a standing, that there's a report as a standing agenda item to QPSC bi-monthly now. On page 3, we're very near our 360 audit target of all reviews completed by the 31st of October. We just missed that by a shave, and that was the reviews booked in October had to be rescheduled. If parents or anybody significant cancels it, we can't go ahead. Obviously, parents for consent issues, and if any significant professional from BMBC can't attend, because they're done at the EHCPs now, they're all aligned with the EHCPs, then we could end up in a dispute if there's an ineligible decision particularly. So we have to be very mindful of that, but all but one are now complete and going to panel on the 15th on Monday. There is a decrease in the caseload from 34 to 16, and I've seen the figures that our CCC nurse Paul has produced, and it's been a phenomenal piece of work since he's only been here since about February. And he has not also done that, he's screened out several cases as well. So in the past, they would have actually converted to DSTs or eligibility, probably, or to more work and possibly more cases. But through his skill and expertise, they've actually been screened out. So there's been a lot of work done to achieve the position that we're in. You'll note that there's on page 3 again, there's been a saving on 6 cases that previously had no CCC eligibility that were decided at what we call the old CRAG panel, previous CRAG, and those cases have been discussed with BMBC colleagues in social care and education, and funding ceased on those cases, which is translated to a saving of about £50,000 a year. Then I come on to the bad news. There's a staff change. Our continuing care nurse, Paul, is leaving. He's tendered his resignation with effect from the end of the month, 26. We're very sorry to see him go. But we have the position covered for reviews until the beginning of next year. Is up to date. So we've got a paper going to SMT on Monday that looks to reuse his post and asks for a little bit of additional, but I'll dilate on that more in the paper at private session. So that we feel that we're in an okay position, even though he's leaving. Complex cases, we have completed all our audit actions. There will be an audit revisit to test that out, and we've got some meetings booked in with the auditors next week. You'll note that there's an increase in Section 117 cases. We've had 29 new cases since April, which has translated to an upswing in spend. Nothing we can do about that, and it's not related to COVID. That we had a recent presentation at CQB, Clinical Quality Board for Swift, which looked at the numbers that are increasing across the system, and there's pieces of work ongoing around that now. The big pressure in that cohort is the step down from the Transforming Care Partnership, and if the spend on such a small cohort is relatively high, very relatively high, and there's nothing we can do about that with the downward pressure from NHS England rightly to discharge those people under Section 117, but that will increase our numbers, and again we're subject to a provider-led market. There's an absolute paucity of placements and the charges are high. So we keep those under very close review. In the acute mental health world, the PQ bed issue continues, where people are needing to move into acute, very acute beds. We've got that under quite a lot of scrutiny, and what we've started to do is the lead for the out of area locked rehab panel and myself are now attending the challenges to discharge meeting to see if we can clear things a little that way. So,
Joe, what I'm going to have to do at that point, Joe, is just interrupt stay, and we're going to ask people to switch off their cameras and microphones for 2 minutes. If we could do that from now and then rejoin. It's meant to be from 11 o'clock. We're going to touch 11 in a few seconds. So if we can have 2 minutes respectful silence, please. Thank you. Welcome back, governing body. Joe, do you want to pick up the final parts of the report, please?
I'll try. Thank you. Yeah, just redirecting you to page 4 around the out of area specialist beds and general acute beds. You can see the sort of the checks and that we have in place now there, trying to keep a handle on that. Weekly reports by bed manager and things like that. And we're actually attending, I just said we're attending the challenge to discharges meeting on a Wednesday to look at whether we can take a bit of a task type approach to that. And unblock things, and I've invited social care to that now as well. On page 4 again, in the neurorehabilitation world, the requests all the requests go through IFR now. Sometimes we have to make a pragmatic decision quickly outside of that process because there's a bit of a week delay on that. But nevertheless, what we do is we put them through the IFR panel as a check and a quality test really, but we sometimes have to make very quick decisions, particularly with the system pressures that we've got. And around that, there's a piece of work going on with the neurorehabilitation unit in Barnsley at Kendry and generally across the ICS that's been led by through the Commission and Transformation team. So we're tapped into that and we're doing some work on our bits of the pathway to try and smooth those out. So really, just like governing body, to note the scrutiny that we've got and assurance that the processes that we've got in place, the committees we report to, and the progress that we've made on our positions. I think we know what we've got and we know what we need to do now, which is a much better position than we were in even 3 months ago. So that's our report for today.
Thank you, Joe. Can I just pick you up on something? Page 129 or page 3, section 117.
Mm-hmm.
There are some quotations under section 117, and it says, today clinical input into reviewing the cases has saved in the region of £11,000 per week.
Yeah.
That's correct, is it? So that's
it is. There's been an increase in spend, but that's offset it, if you like. What we've looked at is since the complex case manager took over, she's been reviewing the cases, but also we've got much more. We've got clinical attendance at panel now, so we negotiate those bandings and the level of funding, and the funding splits much more closely now. But with her reviewing those cases, it's actually resulted in decreasing in banding for some cases from band 5, which is 100% CCG funded, to a band 3, which is 50% funded. That's translated to about an £11,000 a week saving for those people. But nevertheless, we've still got an upswing because we've got more. But that piece of work has saved £11,000 a week in the region of.
Right, I just wanted to confirm that. Thank you. Questions for Joe? Okay. If there are no questions, we'll move on to the ask, which is just to note the update and progress. But it does ask us to agree on the nature and content of future governing body updates.
Yes, I think, Chair, we were asking for if we can just give quarterly updates now because we have quite a lot of scrutiny in place, and I know we've reported to quite a few sessions recently. Yeah. So I think that was the ask, really.
Well, I think, yeah, so having considered that, I think there's a couple of things. One is that we've had governing body development sessions. The other one is that we have on the risk register risks around CHC and complex cases. And I think finance and performance and monitoring the spend monthly. So I think there is quite a bit of scrutiny. The only thing with doing it quarterly is we're only here for another 4 months as a CCG. So it might be reasonable to have an update in January and a final one in March. Otherwise we'd just have one in 3 months falls between that. So 2 more updates, I think.
By all means, Chair, yeah.
Yeah, I think that's reasonable. Is governing body happy with the level of scrutiny involvement that we have with this position and the progress we've made? Or do you feel we need even greater scrutiny? I'd be guided by governing body. I think we're in a much more comfortable position and more people cited on things. Chris?
Yeah, I agree, Chair. And thanks, Joe. I think we've come a long way, haven't we? It seems like we've got on top of this now. It's a case of just keeping on top of it, isn't it? So I think the suggestion of coming back for a further update in January, we can perhaps consider in January whether we need a further one in March, Chair, can't we?
Yep.
Thank you.
John?
Do we get a review of the overspend on CHC taking into account these savings? Because it was quite substantial every month, wasn't it? Talking from a finance and performance perspective, I think it was £300,000 a month, I'm not sure.
Yeah, Roxana, what do you suggest we should have as update to finance and performance? First of all, how would we manage that?
Yeah, so I think we'll include it as part of the financial, the IPR report anyway. So there'll be a standard update, and if there are any requirements, obviously we've had Jane come and present at the committee. So if there are any issues, because Finance and Performance Committee meet monthly, we could ask if things do escalate that she comes. I do need to pick up a conversation with Joe about the efficiencies in this paper compared to what we've been reporting, though, because I think there is some discrepancy. So I think we just need a conversation, Joe, about the numbers that we're reporting through our QUIP scheme to make sure that everything's joined up.
Yeah, I think we need to join that up. It just feels a bit that there's delays. There's a bit of a swing somewhere, isn't there, in it, and it doesn't quite match. So yeah.
That's the point I'm making. That's the point I'm making. It's okay saying we've got savings, but we want to see, on the whole, has our deficit gone down every month? Or overspent?
Okay, and I think we'll see that through the arrangements that Roxana will make, as you rightly point out, John. Nigel?
Yeah, just to add to that, I suppose, it would be useful to have some sort of reconciliation that shows what the savings are and what the overspend is. And perhaps in that, Roxana, we could include the 150,000 you referred to at the last finance and performance. I've forgotten what the committee's called. Finance and Performance Committee, because I would quite like to understand how that fits into all of this. Because it seems to be a bit, and I think perhaps people are looking at it from slightly different angles. So it may well be that all the numbers are right, but they don't mesh together in my mind. So if we could perhaps have a think about that, please.
Joe?
Yeah, just to answer the question on the discrepancies, we're meeting with Finance monthly now, and we're trying to marry up our reporting, because just bear in mind that this report's from our monthly data that the staff send us, and also it's the current position, but this is a delayed position because it's about 3 weeks since we picked up that data. So when we wrote the report, so there is always that bit of delay, but we're trying to pull it together with a report with Finance, and we've discussed that only yesterday about how to refine that some more and get it as good as it can be, really.
Okay, thanks, Joe.
I think that's good, and this is governing body, and thank you for that report, Joe. But I think finance and performance also need to have a good and clear understanding and this reconciliation and the reporting, how that affects it. So thank you very much, Joe. That's been very helpful. Now I'd ask us to move on to item 16. Patrick's here. When we've done item 16, there's a slight change in the agenda. We're going to do 20 after 16, because Richard has to be on another call. So we'll go 16, 20, and then 17. So can we take Children's Services, please, Patrick?
Yeah, thank you, Chair. I'll take the papers being read, so I'll...
Can't hear you clearly.
Can you hear me now?
Yeah, hear you a bit better now, yeah.
A bit better. So I'll just go through some of the key highlights and key points. So in terms of CAMS, I think the situation, considering we have such a significant increase in demand, it's fairly positive in that the waiting times to access CAMS are not increasing. I think governing body members are fully aware of some of the issues in CAMS and generally within the system through a number of development sessions, but also one of the key issues in the eating disorder system. I know that the pressures are continuing to increase. There are some actions that have been put into to mitigate some of the risks in terms of clinical safety because of the huge numbers of children and young people that are now on that pathway. And obviously the recently approved funding for that pathway will help to enhance the therapeutic response that and the appropriate support that's delivered to those young people over the next few months. In terms of some of the specialist pathways such as ADHD, the actual waiting times are coming down, and the on that pathway the partners are working very hard to actually hit the target of people being offered their first intervention, not being seen, which is within 2 weeks, but their first intervention by 3 months. So there's a lot of there's action plans developed for that pathway, and there's a lot of work going on, which members are aware. In terms of the acute and community paediatric service, I think members are aware that there's now newly revised service specification for both the Children's Assessment Unit and the Community Paediatric Nursing Team, and this will both provide more enhanced support to the young people whilst they're within the hospital. There are currently, however, being pressures experienced within the paediatric ward in terms of young people who've been admitted who are physically well for discharge, but because of their ill mental health, they're waiting on the ward for a Tier 4 bed. So that's Tier 4 beds that are commissioned by NHS England. It's not just eating disorder beds that are being waited for, it's other Tier 4 beds as well. Clearly, this has been escalated to our local networks, but it's also been escalated to NHS England, and it is a national issue, not just a local issue, but we also partners are working collaboratively together to look at solutions as to how we can best support the young people whilst they're waiting on the wards at BHNFT. In terms of SEND, finally Barnsley have had their joint SEND inspection, and this happened at the end of September. And whilst we're still waiting for the final report, I think the feedback generally is that it's fairly positive, particularly from a health perspective. That's not to say, however, that we won't receive a statement of written action, because there were some key areas, particularly in terms of parent-carer forums, that were highlighted by the SEND team. But as I say, once we get that final report, we will be made aware of any statements of written actions going forward. In terms of the health support that's provided to the pupils at Greenacre School, we are looking to remodel this service because we want to ensure that we have a robust and effective service to all pupils with SEND in Barnsley, no matter what school they attend. And so we're looking at remodelling this service, which has also been linked into identifying needs more effectively through the Education, Health and Care Plan. So there's a lot of work being undertaken there in terms of the annual reviews, ensuring health are part of those reviews. And we hope to implement the new revised service model by the end of this academic year. In terms of neurodevelopment disorders, but particularly autism, members will be aware that the National All-Age Autism Strategy, which was published last year, and we're now looking at developing a local strategy both to focus on delivering the recommendations of the autism strategy, but also linking in with the issues that are raised by the local people during the current engagement process that's been undertaken. A key recommendation of the autism strategy is that each area should have a autism partnership board, and although we don't currently have a partnership board in Barnsley, particularly autism, we do have an autism steering group. So we're looking to change the steering group into an autism partnership board, and that is most likely to be chaired by local authorities, head of SEND and inclusion. To also better support the young people with autism in Barnsley, we're also looking at two particular issues. One is how we better support young people with autism with comorbidity, i.e. autism and mental health issues. And the other aspect is to look at how we can better support people through sleep deprivation. So we're looking at how we can possibly develop a local sleep pathway. So those are two sort of task and finish groups that have been recently established. And obviously, as we progress and work through that, we'll update governing body going forward. In terms of the youth offending team, members will be aware that funding was approved for speech and language support specifically within the youth offending team, and this will enable the needs of these young people to be identified as early as possible to ensure that the most appropriate support is provided, and this will help to improve the quality of the outcomes of these young people on that pathway. And then in terms of joint commissioning, the Children's Service Improvement Plan is currently being updated and revised by BNBC, and you see a list of all the areas that are actually included in that service improvement plan. All partners, including CCG colleagues, input and influence the contents of the service improvement plan and actually work together to deliver the recommendations of the improvement plan. But as we see, sort of the main challenge continues that the system is faced with increased demand. So it's a constant sort of balance on how to best utilise both the resources that we have in order to deliver the most appropriate and effective support to the young people. So I think going forward, it's a generally positive area within children and young people, but there are sort of key challenges that we still face that we need to sort of look at. But mitigations and actions are being put in place, and partners are working extremely well together. Thank you.
Thanks for that report, Patrick. Do we have any questions for Patrick? No? Okay, Patrick, could I ask then, autism service, a 20-year-old patient with autism or suspected autism that needs assessment, where would I send them? Would they go to CAMS? Is CAMS at, sorry, 20?
They would currently go to SWIFT, to the adult service.
Okay, but what I've been told is that they go to the single point of access mental health access team. Because I thought if there's a cut-off at 18 and not at 25 for CAMS, then they would go to the adult service.
So they if they go to single point of access, they would direct them to the SWIFT adult autism pathway. It's based at Manigates in Wakefield.
Okay, which brings me back to the question of if there's a single point of access at CAMS, and even if they have a cut-off at 18, shouldn't they redirect that rather than send it back to me as a GP?
So currently the single point of access for CAMS deals with the under 18s. So there's a separate single point of access for the adult mental health provision. So there's two single points of accesses currently, one for young people, one for adults and older adults.
Right, so I was confused then, because somewhere I thought I'd read in one of the updates that CAMS was extending its reach to 25.
So we're looking at, as part of the new service specification, we are moving towards the 0 to 25 service, but that's not currently implemented yet, but it is part of the action plan over the next 2 years.
Okay, that's really helpful and gives me clarification. Any questions for Jamie?
So it's not a question, Chair, but just to note the reference in terms of the SEND inspection that we had a little while ago. There's been a period where there's been an opportunity to just send some clarifications back. We're expecting the final report on that by the end of this month. So we should have the final inspection letter by the end of November. And then at that point, we'll look at how we can best sort of report that in and provide governing body with any information or assurances around the plans that we develop for improvement jointly with the local authority on that. So we'll probably bring something in January around the plans around that, because that would be the next governing body meeting.
Okay, so thank you, Jamie. So thank you, Patrick. Thank you for that report. And thank you for that clarification around CAMS and the age. I'm now going to invite Richard to do item 20, the risk and governance exception report for us. And if you'd go through the ask as well, please, Richard. And I think included in there, GBAF risk register, workforce report and the work plan for the governing body. Thank you, Richard.
That's fine. Thank you, Nick, and apologies in advance for my slightly croaky voice. As a result of which, I'll try to keep my my comments relatively brief. I think the update is, a fairly routine one that speaks for itself. So as Nick has just said, in my paper and in your packs today, you've got the governing body assurance framework as always. That's there for governing bodies assurance and information. So that you are hopefully satisfied that we are continuing to review and update and address those key strategic risks that we are facing. You've also got then the full risk register. The full risk register comes to governing body a couple of times a year with updates in between. so the full register is there. There isn't much in the way of change since the last time we reported this. There's no sort of recommendations come through our committees for new risks to be added to the risk register this time. So it's, as I say, it's really there just so that governing body is assured again that the risks that are on there are being reviewed and updated and taken forward by the relevant executive leads and committees. Then you've got the Q2 workforce report for the CCG. We bring these through governing body again twice a year for you just to see what the trends are in terms of staff turnover, staff sickness absence, and compliance with mandatory training. You know, the broad message I think from that paper is that we are continuing to see, notwithstanding COVID and everything else, pretty low and pretty stable levels of staff turnover, low levels of sickness absence, and pretty good rates of mandatory training compliance. Although in respect of the last one, we always strive to get to 100% if we can in terms of training compliance, and we've agreed through senior management team that we'll have another sort of push on that over the next few weeks to try to make sure that our staff have got their training bang up to date before we start that process of transitioning into the new organisation. And then finally, you've got the governing body work plan for what is now going to be essentially the final 2 meetings of this governing body. It just sets out the papers that we've got actually on the schedule to come through in those last couple of meetings. But again, recognising that there's always the potential to add things to that or to move things around if that proves necessary as we go through the sort of the change and transition process, really. So that's all I was going to say. Before I do the ask, is there anything that anybody particularly wanted to pick up on or ask?
I think they've all read the papers really well. Perhaps they anticipated the croaky voice.
Yeah, I think that's right.
Would you kindly take us through the ask of the governing body?
I will indeed. So as far as the GBAF is concerned, it's to review it and consider whether the risks are appropriately described and scored, and whether you as a governing body have sufficient assurance that they're being effectively managed. I'm just pausing and seeing no hands there, so I'll move on to the next one, which is to identify any additional positive assurances relevant to the risks on the GBAF. And again, I'll take the absence of hands as assent to that. Then we've got the ask to review the risk register and confirm that all the risks are appropriately scored and described, and identify any potential new risks if you feel that there are any that are not reflected on there. So again, I'll take the absence of hands as compliance with that. You then have to note the Q2 workforce report, and then finally to receive and provide comments on the governing body work plan and agenda timetable. So if anybody did have any comments or felt that anything was not on that timetable that needs to be, feel free to say so now, or alternatively contact myself or Kay outside the meeting and we can address that. So that's the ask, Nick, if that's okay.
Yeah, get well soon and enjoy your next meeting, Richard.
Thank you. Cheers.
So, thank you. Could we now move on to, I think, Angela Fawcett, Leanne Sparks, Angela and Leanne. If you could take item 17, Children's Community Nursing and Assessment Unit, Spec, please.
I was going to introduce this, Chair, if that's all right.
Sorry?
I was going to introduce this, if that's all right.
Oh, good, a change.
So yes, it's thank you very much to Angela and Leanne for all the hard work. The discussion is regarding the progression of the spec for the Children's Assessment Unit and the Children's Community Nursing Team. This is a progression of the NHS long-term plan and also the pre-existing work in admission prevention that's been done sort of secondary to COVID. The Children's Assessment Unit is been sort of work in progress for the past several years. It's now been physically integrated with the new kind of paediatric A&E. It's a dedicated 24-hour, 7-day-a-week service for the 0 to 16 age group, and comes with the advantage of patient flow coordinators to facilitate admission, both for primary care, emergency departments, and sort of 0 to 19 service and other people who have access. It allows for observation for up to 24 hours without the need for admission, plus an open access 40 hours post-admission for anybody discharged. The children who have complex health needs do have direct access as well. But at present, any kind of trauma or surgical admissions will not be seen unless discussed with the appropriate on-call reg. At present, they haven't set up KPIs other than the desire to collect data appropriate, but the plan is to put KPIs in place before October 2022. The idea for this was that it's a relatively novel situation, and therefore, rather than put unhelpful KPIs in place, it's felt to be better to observe and then put in some effective ones. The Children's Community Nursing Service is again a progression of the long-term plan, where we're trying to wrap care around the children in the community. The progress from this is it's now going to be a 12-hour per day, 7-day-a-week service from 8 AM to 8 PM. With the acute service and a sort of chronic disease, complex chronic disease service. The acute service is going to be focusing on 2 factors predominantly initially. The first is respiratory conditions, and the second is for those children suffering from gastroenteritis. And both groups are going to be offered in-house visits by a nurse to review and assess. The complex long-term health needs conditions, obviously, is going to be the children who have, as the name suggests, the more complex needs where they require additional kind of paediatric input, but hopefully without the need for admission. The KPIs in this regard are going to be based around reduced length of stay for admission and reduced readmission rates as a sort of standard. I will note that in the service specs, there has been a slight change after discussion with BHNFT, which unfortunately hasn't been done in time prior to this meeting. And it's recorded in the specs that services such as suture removal, IV or IMA injections, or stoma care, and a few others, looks like it's being offered for all children, where actually it's only going to be offered to those who have complex patients. Thank you.
Questions for Jamie? Some of my GP colleagues may have some. John?
You muted, John.
Yeah, the community service, is that run by SWIFT or BDGH?
I believe that's BGH. But Angela or Leanne will be able to correct me on that.
That's correct, yes.
Yeah, I'm just wondering, because we've spent all this time and effort developing neighbourhood team, whether it should have been linked into that as one team for the community. That's my question.
I think the support that the paediatric community nurses are going to get is from the paediatric consultants. So it makes more sense at present to have it embedded within BGH.
Yeah, but the support that the breed nurses are getting for adults are from the BDGH consultants.
True.
It just seems we're fragmenting, and if we're going to go towards a model of community-based care, then where it should sit is in neighbourhood teams. I would think. I don't know. I don't know if anyone agrees with that or not.
We have included it.
When you said respiratory problems, we just spent a lot of effort doing breathe.
So who was that? Somebody's trying to get
to respond. Yeah, within the service spec, we have acknowledged that there is a need for development from the children's community nursing team within to link in with those neighbourhood teams as well. I think the caseloads are slightly different
and the kind of the needs of the children for kind of reviews and going into schools are slightly different. So that's why it's currently separated, but absolutely acknowledging that they do need to link in and for transitions, if nothing else, into adult services. So that is acknowledged as part of a kind of development plan.
Okay, I think Mark, you had your hand up.
Yeah, I was going to say something similar, because I think a significant proportion will be children with complex needs who are perhaps better known to hospital consultants than to us. So that probably explains part of the difference.
Thank you, Mark. Can't see any other hands. I've got a couple of points. One of them is the referral sources into the Children's Assessment Unit. And I just want to check that this is real, because I don't want it to end up being another school nurse thing where everything's referred back to the GP to refer to the Children's Assessment Unit. And it says the referrers are ED, primary care, but then it also says community midwives and 0 to 19 practitioners. How is this going to be communicated to the midwives, 0 to 19 practitioners? And how are you going to monitor that they are actually referring to the Children's Assessment Unit rather than saying you need to see your GP? And so this mimics what we had with school nurses, referring perhaps to CAMS and doing other things. So what's the process for developing the skill set of these practitioners to feel confident enough to refer without going back through the GP?
Shall I come in?
Yeah, somebody needs to answer. Yeah, come in, Angela.
It's not actually changed for many years. Midwives and health visitors and school nurses are directly referring to CAU. So although CAU's changed how it's working, that referral process hasn't changed. Even when I was an health visitor, I referred into CAU. So it's not actually a new initiative, that part of it.
Well, that's interesting, isn't it? Because I've been a GP for nearly 31 years now. And I can't remember many people, I can't think of any, maybe I'm getting old, that have been, I can remember some babies, very young babies, and we understand that, yeah. But I can't remember, I haven't experienced 0 to 19 practitioners referring into the Children's Assessment Unit. My experience has been for an appointment being requested urgently for the GP to see them do it, which is fine. But so I think there is going to be a change for most of your colleagues, and they'll only do it if they've got the support and the skill set to do it. Otherwise, it'll come. Yeah. It
does happen more for babies. I think you're right. I think midwives use it a lot, and health visitors in early days use it more for babies. Yeah. What we can do is promote it again, but it's not actually, they have always been able to refer, but I think, you know, if they're not utilising it properly, then we can do a communications around that and speak to relevant teams.
Okay. Do you want to come back in on that point, Leanne?
Yeah, I was just going to add, Nick, on that, that kind of point about the confidence and the assurance. I think that's what the patient flow coordinators will do as well, as being a kind of point of contact to the CAU before they say, yeah, bring them in. Yeah. You know, professionals can ring that line and have that discussion beforehand.
Okay. And then the other question is the open door access. So that's currently, for a lot of cases, only like 24, 48 hours. So, you know, those criteria may be relevant, but a lot of illnesses persist for longer than 24 or 48 hours. So maybe that needs to be looked at, particularly with respiratory things, because otherwise the only way to get back in is for parents to take them to A&E or to come to the GP. And it may be for some of the conditions that a longer period would be appropriate. And you'd perhaps have a look at the evidence around that and see what best practice is elsewhere. But we tend to see a lot of patients who've rung up and been told to come to see the GP on day 3 or 4, and it's the same condition. So that might be an efficiency. The other point in reading this is, having chaired the CCG as a commissioner for 9 years, I find it interesting that there are no KPIs in this. apart from collecting data. And if we look at what the objectives are, which are to reduce unnecessary admissions, various other things, perhaps there ought to be some KPIs, because otherwise, how on earth are you going to know that you're doing a good job? There's got to be something measured, hasn't there? And that may be part of the thinking of the bit where you put data collection. But from my perspective, I would say something has to go in there which are outcome measures, and some of them may not be just simply numbers, they may be more qualitative, but I think there has to be some outcome measures. And I think they're not just for the commissioner, they're for the confidence around the service, but also for people working in the service to know that they're making a difference, so that they can point, say, since we started working in this way, we've achieved X. So I think that, from my perspective, needs looking at. So those are points I had to make, but I think it will be a good step forward, and particularly with the follow-up. Do anybody else on governing body have any comment to make or question?
I suppose, just in response to your KPIs, the data will be collected regarding admissions, readmissions, length of stay. All the sort of standard information will still be collected as part of the KPIs. It's just that there's not having a kind of an assessment based on it at present. Yeah.
Then I would have liked to have seen that in the paper, what's being collected, because if we know what's being collected, we can get an idea of what would affect outcome. So that might be all that you have to do, to list the data that would be collected to start with. Yeah. Okay, so we're asked as a governing body to provide comment, which we've collectively done, and approve these two specifications. Do we feel comfortable to do that? Yeah. Yeah. Okay, that's good. So thank you, Jamie, Leanne, and Angela. So that was item
thank you.
17. Okay, now we're on 18, quality highlights report.
Yep.
I don't think I missed anything out, and we were going to ask Madhvi to do that because Jane's not here. Thank you, Madhvi.
Thanks, Chair. So this paper is for information and assurance, and I'd like to draw your attention particularly to the 4 areas in the amber and the red list. So I'm just going to go through individually. So the first one is Barnsley Hospice CQC update. The Chief Nurse provided QPSC with an update on Barnsley Hospice's progress towards completing their CQC action plan following the inspection which took place between 28th of April and 4th of May. The hospice expects the CQC to provide feedback on the plans in mid-November. QPSC also informed that the Chief Exec had recently changed. Early feedback from the new post holder indicates that whilst there is lots of positive changes and improvements have been made, there is still work to be done to strengthen the communication and engagement with teams and overall governance systems. So QPSC noted the ongoing work to implement the required CQC actions and agreed to monitor the progress. The second item is the lymphedema service update. QPSC received an update about the recent cessation of the lymphedema service operated by Barnsley Hospice for cancer patients. The committee was informed that CCG is liaising with SWIFT for them to provide the service, but this will take 4 to 6 weeks to implement. Therefore, to ensure the clinical oversight and continuity of care, CCG has put on an in-house nursing service in place to support via the medicines management team in the interim. So the committee noted that the latest position with regard to the lymphedema service for cancer patients, and they agreed the importance of service being commissioned properly. So there has been sort of interim plans put in place whilst it is being taken over by SWIFT. The next item is the SNAP, which is the Sentinel Stroke National Audit Program. The committee was updated on discussions with BHNFT on 1st of October regarding the SNAP audit results for stroke patients admitted to and or discharged from BHNFT between April 2019 and March 2020. The data identified BHNFT as a mortality outlier. The Trust has developed an action plan and shared its key actions with the CCG. The Trust provided reassurance that the current actions will be implemented within the timeline. It is to be noted here that the data results are historical, so the Trust may receive a further outlier notification letter in the future again. QPSC noted the audit results for BHNFT for 2019-20 and noted the further updates will be provided at BHNFT Clinical Board. The next item is Oncology Provision Services. QPSC received an update on changes to oncology provision in Barnsley and plans to create a hub and sub-hub model with Doncaster, Weston Park, Sheffield and Chesterfield. These plans are in response to staffing issues at Weston Park Hospital, which are likely to remain for some time due to shortage of oncologist capacity, not only in South Yorkshire and Bassetlaw region, but also across UK. The committee received the details of potential risks that may arise from the change and the actions being taken to mitigate these whilst a long-term solution is being developed. So QPSC noted the update and agreed that a risk should be put on the risk register about the potential impact on Barnsley patients. Any questions?
Any questions? Okay, well, I've got a couple. First one is Barnsley Hospice. And as the CCG has always offered support to the hospice for a variety of things, I find that the new chief exec comments there's obviously still work to do, both with teams and it says, and the overall governance systems. So in effect, if we have an amber, I just wonder what the action plan against that is, because the hospice is an institution that will remain after the CCG has gone. So I just wonder what the plan is to be able to continue to support the hospice and what there might be that we can do while we're still here, and how that support can be transitioned then into the place-based arrangements, because Barnsley will still need its hospice. And there have been over the years different sets of issues, as with every organisation, but the hospice is small compared to some of our providers. It's a very important and publicly well received service and respected. So I just wonder what else there might be that we can do to support them, both as CCG and subsequently in place-based arrangements. Chris?
Yeah, so just to try and respond to that question. So what we've been doing with the hospice, we've been putting some support in there, but the sort of things we've been helping with have been in terms of information governance. Barnsley Council have been very helpful in terms of looking at board membership and making sure they've got appropriate, robust board membership. And also we've been looking at things like development plans and OD plans, see if we can help them source support. So I would expect the Barnsley Place team within an ICB to continue that. And it's just advising on good practice, help them identify and support as and when appropriate. So I would imagine that would continue through a place team in an ICB, Chair.
Right. Okay. So before I bring John in, there's another bit I've got, and that's oncology provision, which is red. And it says QPSC noted that and agreed a risk should be put on the risk register. So I'm going to take some learning from Chris Millington here, who always tells me there's no point putting anything on a risk register unless you've got a plan to mitigate it. So what's I just wonder if quality and patient safety feel comfortable that they've got some sort of mitigation plan, because the other thing that this will do, when you have a hub and spoke model, if you're not careful and if it's due to decreased capacity, you run a big risk of widening health inequalities. So I just wonder if it goes on the risk register, perhaps quality and patient safety could advise us on some of the mitigations that have been offered and also the things that we might be able to do as a place.
Yeah.
Got lots of hands up now. I'll take them in order. I think John, yours was the first.
Yeah, Nick, just on the financial aspect, Roxana, if the lymphedema services close down, is funding for that included in the grant to the hospice? No. So it's a separate contract, is it?
It's a separate amount of money, yes, and we're working
Yep.
with Swift on the development of the new service.
So that money will go out of the hospice, yeah?
Yes.
Okay.
I think that's been to SMT, so there is some scrutiny around this service. It's been there a number of times. So I've got another hand up from Chris Millington.
Thank you, Chair. In relation to the hospice, I think we've worked pretty quickly and swiftly and slick actually to get the bit sorted out. And I take on board what Chris Edwards, our Chief Executive, has said in relation to the support. But you're quite right, Nick. It's a treasured area of health in Barnsley, and in the handover, I think I would need to be well assured that in fact the hospice is still being supported. So I'm taking the assurance, Chris, that will happen. In relation to the oncology service, yeah, you're quite right, Nick. I do go on and on about the risk register. It's easy to put them on the risk register, but getting it off and getting it under some sort of control. And only this morning, that the reason why I was late here, I've experienced what happens at this moment in time. And I appreciate that we're in public. But there's a big job to be done for patients in Barnsley who are suffering from particularly breast cancer. So I will watch that very, very carefully. And we've obviously not got to a situation where we are scoring it at the moment, but it's in the Millington world, it's going to be pretty high, really. So that's as much I want to say this morning. Thank you.
Thank you, Chris, for that sincere contribution. Mike.
Yeah, I mean, a lot of this on this paper is result of two factors. First of all, a lot of essential services in this country, including hospice services, air ambulance, even the lifeboats, are charitable institutions, and yet they are essential services. And what happens at a place like the hospice when all their shops and charitable support is stopped for a year, the whole service starts to disintegrate. And I think this is a comment on how the NHS is funded. The other part of the NHS funding problem, of course, is manpower planning, and the oncology service, which we are having repeated problems with, is because of poor manpower planning centrally in the NHS, and we can do very little about that. And I think both of those, my comments should be noted.
Thank you, Mike. They'll be noted. Any other points or questions to be made? Okay. Thank you, Madhvi, and thank you for everybody who contributed to that. And perhaps we could also just have a think about the hospice, because there are two bits to this. There's what comes after the CCG, but there's also what we create as a legacy and how we direct what comes after and set our expectations. And perhaps we could, outside the meeting, therefore, just have a short chat with, I don't know, both Chris's, perhaps others, about how we continue to support the hospice to make sure it continues to be supported. Okay, thank you for that, Madhvi. Angela, could you please take us to item 19, Annual Children and Adult Safeguarding Report, please?
Yeah, if it's okay, just to save time, I'll do them jointly because I think there's very common themes actually running through both papers. Just to pull out the highlights, because I'm sure people will have read them and can ask questions. It's been a busy year. When we came out of lockdown and children went back to school and all, even for vulnerable adults, I think it was a national picture that we saw a steady increase in safeguarding referrals that's continued. I I think it's probably worth adding to that. What we've seen as well is some more serious incidents than we were seeing previously. So it's not been a great picture. The work of both boards has continued throughout pandemic. They were very quick to adapt to virtual working, and indeed, like everyone else, will be keeping very much elements of that going forward, although there will be an hybrid approach to things like training. They had a vacant manager post for 12 months in children, which made things difficult, but I'm pleased to announce we have now got a new children's partnership manager. The other big change in personnel is that the children's board manager will be leaving this month, and we will have a new independent scrutineer rather than a board manager, so that's a slightly different change of role. And idea of that is to bring more sort of independence challenge scrutiny to how the board operates. I think the other thing that's worth pulling out for both adults and children is neglect has been a significant factor. It always has been, but I think we're seeing, you know, continued increase in neglect, but also a continued or a new emphasis by all agencies on neglect, particularly police, who are making it a feature. Currently, it's very high on their agenda in addressing it and looking at prosecutions, whereas previously, you know, they might not have traditionally prosecuted for things like neglect. So, yeah, that's probably been the main feature of the last 12 months. I will leave it at that, if that's okay, and ask if there's any questions.
Yeah, there's one immediate one, and that is the level of challenge and scrutiny, because that's always been something that has been fairly strong.
Yeah.
So,
yeah. There's been a review for children's. Are you
the one you described?
coming
Yeah.
out?
Yeah.
Yeah, children's partnership. I don't think that it hasn't been strong in past or robust, but the partners felt we needed a different approach to it, and an independent scrutineer, I guess, brings a different element to practice. So that there's been a review of how the board operates, and on back of that, discussions between partners and agreement that we look for an independent scrutineer.
Okay.
I don't think that means there hasn't been challenge in the past, though, because I think, you know, we have made a pretty good, we have made a good job, I think, of challenging each other as agencies previously.
Yeah, but it is interesting that we've received reports from various agencies for assurance, and we've received those as assurance on the premise of challenge. So how can I put it? So we welcome and congratulate the board on its recognition for more independent challenge, perhaps.
Yeah, yeah.
Chris Millington. Thank you, Chair. You've stole my thunder, really, in that the question I was going to pose, you've posed it on my behalf, so thank you. It's quite important that we do follow through, and my only concern over and above all is the levels of potential duplication with this service. I mean, I sat yesterday afternoon for a good 20 minutes and listened to our local hospital in relation to children and adult safeguarding. So there are enough fingers in the pie. It's important that you know, we've got to understand that the headline of safeguarding. So I was quite pleased when I saw the fact that we are going to do something about the partnership board manager. So that's a good move. Thank you.
Thank you, Chris. So I can't see any hands up. Okay, so thank you for stepping in, Angela, to deliver that for us. Can we now move on to finance and performance? So we've got item 21, integrated performance report. Roxana, the next one is operational and financial plan. Do you want Jamie to do the performance bit of this report first, and then you can do the financial bit and lead into the other? Is that
yeah,
okay?
that's fine.
So I'll invite Jamie to describe the performance for us.
Thank you. So as usual, this report and the details behind it have been discussed and considered by the Finance and Performance Committee. So I'm picking out some key areas just to highlight within this report. I think the key things, and some we've referenced already in other items. So urgent care performance continues to be challenged. So A&E against the 4-hour target is still well below what was the sort of 95% target, 71% in September. Attendances continue to be high, so you saw the graph earlier which shows that in the same period attendances were higher than we've ever seen before, and as you would expect, as that part of the system is very hot, there are challenges in ambulance services as well, and because of the busyness of the ED department, that has resulted in some increases in terms of ambulance handover delays, which is fairly rare. Usually in Barnsley we've got a really good process, but to avoid sort of corridor care and other things, there have been occasions when patients are waiting in ambulances, so that's been higher than usual. In terms of planned care, so it's a slight reduction, but it's only a tiny sort of variance around 18-week performance. So as more referrals come through and things, you know, performance is still around 85% of people waiting less than 18 weeks, as opposed to the standard, which is 92. So we're still generally on a positive trajectory, but a slight dip in September. We are continuing to see the decreases in longer waits. So further reductions in the numbers waiting over 52 weeks. In terms of diagnostics as well, we're seeing a bit of improvement there. So it's steady, but less people waiting more than 6 weeks for diagnostics. And the longer waits there are mainly around colonoscopy, gastroscopy and other things, which obviously have been fairly severely impacted by COVID and the ways of working. In terms of mental health, I think most things are in line with where we would expect there, so continue to improve on the access target, so not quite where we want to be, but getting close now, and the 50% moving to recovery target, which for mainly technical reasons, but a bit of data cleansing and other things that dipped down, is now back where we would expect and above the target. Just in terms of cancer, I'll give a bit of an update on here. So the cancer data that were included in the report was only available up to October. We've got September's now. So whilst we were flagging, you know, most of the cancer performance targets were not being achieved, actually in September there's been improvements around the cancer 2-week wait, so that has now increased and is above standard. Breast symptoms 2-week wait is also now above the standard. We're making improvements across all areas of the sort of 31-day subsequent treatment, so following diagnosis. So where it's drug treatments, we're achieving the target. For radiotherapy and surgery, not quite there, but stepping up, so some improvements there, but still challenged. And I think that is probably everything that I would want to flag to governing body, but as usual, any questions I'll take before we hand over to Roxana.
Any questions for Jamie? No? Okay, could you take us through the financial part, please, Roxana?
Yeah, so in terms of month 6 then, we're continuing to report a break-even position. We do expect further allocations to be able to achieve that as at month 6 of 462k, but those will come through NHS England as part of the normal reporting process. Risks in terms of the financial position because of the blocks continue to be in the same areas as we've previously reported. So the biggest risk for Barnsley currently is around continuing care, and we've already had a discussion about that earlier. In terms of efficiencies in H1, these have primarily been delivered through in-year flexibility as opposed to planned schemes, with the exception of prescribing. So prescribing does continue to deliver the associated target and is actually reporting slightly above that for the first half of the year, with the aim of still delivering the full value of £3.5 million towards the end of the year. In terms of the financial position, clearly we need a full year forecast position for the governing body to commit to review, and that will be provided during the next couple of months as we've signed off the H2 plan, which is obviously the next paper on our agenda today. The budgets have not yet been uploaded actually to the ledger, subject to governing body approval today, so full reporting is likely to commence during month 8 and 9. So it's just for the governing body to note that there may be a slight delay in month 8 and that we'll have a full position, and we'll review any sort of flexibility as part of our governing body session in January. So that will come to the next meeting. So I just wanted to note that here today. And I'll just pause there in terms of the H1 position if anybody's got any questions before I move on to the plan.
Okay, so I think what we'll do then is if there are no questions, we'll take the item 21 and just cover off the ask of the governing body, which is to note performance 21-22 and projected delivery of all financial duties on the assumptions outlined and the mitigating actions. So the governing body's noted that, so that's fine. So could you take us then on to item 22, operational financial plan H2, please?
Thank you. So in terms of the financial position, the Finance and Performance Committee have been presented with a number of updates in relation to the second half of the financial year, which is referred to as H2. They've supported the submission of the financial plan to the ICS, so the final version of the plan was submitted earlier this week with some minor changes. The paper asks that the governing body approves the budgets for H2, but noting the following. So in section 5.2, that sets out for the governing body details of the allocations that we will receive for the period October to March. We still expect further allocations from the ICS and national team, particularly in relation to, we've had an email this morning around mental health, but there are also some further expectations around primary care. So we are expecting further allocations in relation to primary care and delivering kind of winter pressures, winter resilience, and providing further assurance around that area. Then section 5.3 details the level of efficiency requirements. Now this is slightly different to what's been previously reported through the governing body. So this is after any in-year flexibility has been accounted for in the position. So that's why it's a slightly reduced position to what we would normally see. And the Finance and Performance Committee again have seen a significant level of detail around that. H2 total efficiency is 3.8 million, of which 1.7 million will be delivered through prescribing and the rest through running cost 300k and flexibility that we may have through discussions with our providers. The total efficiency requirement for the year, so this is 21-22, we've now got a target of just in excess of £11 million. And full reporting against that £11 million will come through to the governing body as normal as part of our IPR report. Of that £11 million, £3.5 million will be delivered recurrently through prescribing, and it's likely the rest will be delivered only on a non-recurrent basis. So that links to the conversations we were having earlier around the underlying deficit position the CCG has, and we do need to do some further work on what that position looks like across the ICS. Section 5.4 provides a summary position, budget position, and the full summary position is included in Appendix A for approval. and I'll pause there if anybody's got any questions, and then move on to the ask if that's okay.
Okay, so I can't see anybody wanting to ask questions, so if you just take us through the ask, please, Roxana.
So if we can, first, I'm just trying to find the report, sorry, and get to use the correct words.
I think it's on page 302.
So we'll note the details of the allocation received in H2. Note the efficiency requirement for H2. Approve the budget for H2 so that we can upload and commence reporting against the budget, and then note the full year report, noting that there'll be a full analysis of that financial position coming to the governing body in January.
Thank you. Are we happy with all that? No dissenters? Okay, thank you, Roxana. So we're happy to approve all those bits we've been asked to approve, and we've noted the bits we've been asked to note. Okay, thank you. So thank you for that. So we move now on to a series of committee reports and minutes. 23.1 is the unadopted minutes of the Membership Council of the 8th of September. Happy to take any questions. Any questions? No. So we move on to 23.2, the unadopted minutes of the Audit Committee, 16 September. Nigel, is there anything you wish to pull out for us there?
No, I think it was a fairly straightforward meeting.
Right.
Happy to take any questions.
And if there are no questions for Nigel, we'll move on to 23.3, and there are two sets of minutes. There's the 2nd of September 21 and the 7th of October 21, and then there also is the 21st of October FMP meeting, which was carried out to support the H2 submission. We've approved the financial plan. Are there any questions there? Okay. And then we move on to 23 for the Primary Care Assurance report from the Primary Care Commissioning Committee, 30th of September with minutes from the 5th of August. Chris, is there anything you wish to draw out from there?
Not at all, Chair. The August minutes have been adopted. Health assurance, obviously, the September minutes, which have yet to be adopted, there were no highlights recommended.
Thank you. And then I've got 23.5 minutes of the Quality and Patient Safety Committee of the 19th of August. Madhuri, anything there that you feel you need to bring to our attention, given that we've had the report from Quality and Patient Safety?
No, nothing else, Nick, no.
Okay, thank you. And then we move on to Health and Wellbeing Board minutes, 7th of October, which I chaired in the council chamber, so happy to take any questions. The only thing I would draw out of that was that we asked the support of the Health and Wellbeing Board for a zero tolerance position on abuse to any health and social care worker, in fact any delivery, any provider that delivers care to people, and that was accepted as it was previously at the Integrated Care Partnership Board, and we're putting together, I think Jeremy has crafted together for us what the wording of that zero tolerance of abuse for health and social care workers. So happy to take any questions. Can't see any. Okay, thank you. So we move on to previously circulated reports, which are there for information and assurance. And I think that brings us to the end of the public meeting. Are there any issues that have arisen that we feel we have any training needs around, or anything that could have been done better? If there is, let me know. I think we did stumble upon any other business, but I think we've got that information during the meeting. So thank you for that, Jamie. So at that point, we'll close the meeting. So thank you, governing body members. Thank you, members of the Barnsley public. Thank you, Kay. And we'll ask the permission of the governing body to go to the private section where we exclude the public and press from the meeting. Thank you. So it's 12 past 12.